Good evening, all. Welcome to the third session of our foundation course in palliative medicine. I welcome you all to the session. And today, for the session, we have Dr. Arjun M. Pillai as our faculty and Hashmat Madam as the facilitator. So, I am over to you, Hashmat Madam, for faculty intro and more about the facilitation part. I will be sharing the intro slide of faculty.
Thank you, Ambari.
Second.
Good evening, everyone. So I'm Dr. Hashmat Farhana, and I work as a palliative care physician at Pallium India for more than 2.5 years. So it's my utmost privilege to introduce the faculty for today, that is Dr. M. Arjun Pillai, who is currently affiliated to the Department of Palliative Medicine as a junior resident in MNJ Institute of Oncology and Regional Cancer Center, Hyderabad. He worked as a palliative care physician in Pallium, India previously, and he also completed the certificate course in pain and palliative medicine from Pallium, India. So over to you, Dr. Arjun, for today's session on management of pain, part 1, where we'll be dealing with WHO analgesic ladder step 1. Thank you.
Thank you, Dr. Hashmat. So I'll share my slide first. The screen sharing option is disabled for me.
One second. Try now, sir.
Okay, 1 minute. Is it in presentation mode? Is it in full screen?
Yes, Dr. Arjun.
Okay. So, Dr. Hashmat, shall I start then?
Yeah, sure.
So, good evening to all. My name is Dr. Arjun. So, I'm currently doing my DNP in palliative medicine at MNJ Institute of Oncology and Regional Cancer Center, Hyderabad. So, I'm the final year resident for palliative medicine at my institute. So today I have been asked to moderate a session regarding management of pain. That is step 1 of the WHO pain ladder. So I'll take a brief session of that. So today's agenda is, like, I know all of you might have been gone through the step ladder already. So I will briefly once again go through the WHO step ladder, and I will briefly discuss about NSAIDs, then paracetamol, and about the adjuvant analgesics. So if there is any concerns, you can just raise it in the chat box, and I will try to address it that time itself or after the end of the session. Okay. So regarding the WHO pain ladder, so all of you might be aware of the 4-step pain ladder, which is a worldly accepted way in which you manage cancer pain. So this is the WHO pain ladder, the 4-step one which we use. So today my focus will be basically morely on the step 1 of this. So as you know, there are 4 steps. Step 1 consists of the non-opioids and other adjunct analgesics. And if the pain is not subsided with step 1, we go to step 2, which consists weak opioids like tramadol, codeine, and buprenorphine. And even after that, if the pain is not relieved, we have to hike it to step 3, where it's the stronger opioids like morphine, fentanyl, methadone, and all. And even if after step 3, the pain is not relieved, we can go for interventional pain management, which includes nerve blocks, epidurals, PCA pumps, and all. As you can see, the new WHO step pain ladder is bidirectional. It's not like a step 1, you have to go to step 2 and step 3. If based on the patient's pain relief and response, we can even de-escalate the steps, or we can also hike it. And in this, we will be discussing today about step 1, like this, the non-opioid analgesics and NSAIDs. And as you can see in this pain ladder, non-opioids or analgesics are present throughout the entire steps of the pain ladder. That is that it's not limited only to step 1, but also in step 2 as well as step 3 of the pain ladder. And considering the other steps, NSAIDs and adjunct analgesics are much more important when you say consider it, because these are the most commonly available analgesics worldwide. Like if you have if any of us has got any pain or any distress, if you go to the nearby pharmacy or medical store and we inform the pharmacist there that we are having pain, more often than not, we are given a prescription of any diclofenac or acetaminophen, which are commonly NSAIDs. And these are the medications which are commonly practiced in our medical fraternity itself. Like any person with pain, whenever they walk into any ER or any other clinic as such, they're usually prescribed on NSAID initially. So we need to have a basic understanding of how these NSAIDs work and what are its side effect profile. And the next medication is about paracetamol. So paracetamol is present in every household, if we can say. And most of the time, if there is any symptom, any distress in our house, first medication is most of us take as paracetamol, be it fever, pain, or anything, stomach pain, or any else. First medication which we always try is paracetamol. And after that, if the symptoms are still persisting, we go to the people usually seek medical attention. So NSAIDs. So all of you might have been prescribing NSAIDs in your practice. So if it's possible, can you please put in a chat box which are the more commonly used NSAIDs that you people prescribe? Like each one of us might have a favorite NSAID. So can you, if you please put in the chat box which one you're prescribing? It would be helpful for me also. So diclofenac was there, aceclofenac, brufen, yeah, naproxen, meloxicam, paracetamol, yeah. So yeah, that would be fine. So all of us are aware of one or the another NSAIDs, and these are our go-to drugs whenever there's any pain as such. Irrespective of the nature of pain, we always prescribe NSAIDs as our first line. So it's always a good thing to have a better understanding of how these medications work. So NSAIDs, as this name suggests, it stands for non-steroidal anti-inflammatory drugs, and it is used. It has got three mechanisms usage. One is used as an antipyretic, it's used as an anti-inflammatory, and it's used as an analgesic agent. We will be more focusing about the analgesic aspect compared to the antipyretic and anti-inflammatory part. However, I will also touch about these two things. So how does this NSAIDs work? What is its mechanism of action? So this is the basic physiology which we learned in our first year, second year of our undergrad. So if all of it, you may be able to recall that there are phospholipids in our membranes, and from these phospholipase enzymes act, which in turn produce arachidonic acid. And from this arachidonic acid, by the action of COX enzymes, prostaglandins are produced, which in turn can be differentiated into PGE2, F2 alpha, I2, thromboxane, and thromboxane B. This is the normal mechanism which happens in our body. So why is this important? As you can see, prostaglandins are not like stored in our body. It is always produced as a response for a mediator or to an inflammation such. So whenever we see NSAIDs in a single word, what NSAIDs does is that it inhibits prostaglandin production. And the way it goes about it is by inhibiting the enzyme responsible for production of prostaglandins. That is, it inhibits the COX enzyme. So the way NSAIDs works is inhibition of COX enzyme, and this in turn inhibits prostaglandins. So when we say COX enzyme, there are two types of cyclooxygenase enzyme, cyclooxygenase 1 and cyclooxygenase 2. So cyclooxygenase 1 is present throughout our body in all the tissues and cells. However, cyclooxygenase 2 isn't present in all our body cells. These are inducible in the sense if there is an inflammation, as a response to that, these enzymes are produced in our body, and as a result, prostaglandins are produced to the COX2 pathway. So this is in a nutshell of how the NSAIDs work. So as I said, mentioned earlier, COX1 are constitutive in enzyme, and from them we produce prostaglandin E2, prostaglandin I2, and thromboxane 8. And if you can see, I've also mentioned certain sites where these enzymes, where these prostaglandins are present. Like prostaglandin E2 is present in our kidney, prostacyclin or PGI2 is present in our gastric mucosa and endothelium, while in platelets there is thromboxane 8. All these are produced through the action of COX1 enzyme, while COX2 enzymes are inducible by the actions of inflammatory mediators. So why is this important? If you recall, the side effects of NSAIDs is much more linked to these actions. If you're able to recall which enzyme is inhibited and as a result, which of the prostaglandins are inhibited, we'll get a better understanding of the side effect profile. If you can see, most of the most common side effect which we see with NSAIDs is the gastric side effect. That is due to its action on the prostaglandin. I'll be speaking about the side effect profile later on. So, how does it work? So, the anti-inflammatory action is mediated by its inhibition of cyclooxygenase. This in turn decreases the formation of prostaglandins, which in turn inhibit inflammation. But one thing we need to keep in our mind is that it doesn't arrest the progression of disease nor induce remission. So whenever we are prescribing NSAIDs for the management of any inflammatory condition like rheumatoid arthritis and all, the disease is still persisting. It doesn't change the disease as such. It only gives a symptomatic relief for that. The next section, which we are more concerned about, is the analgesic action. So the analgesic action, how it works is that there's a prostaglandin known as prostaglandin E2, which in turn sensitizes our nerve endings to actions of chemical mediators of inflammation, like bradykinin and histamine. So this in turn causes increased sensation of pain. So once the NSAIDs inhibit the COX enzyme, there's decreased production of PGE2. This in turn decreases the sensation of pain. So this is why we usually prescribe NSAIDs for the management of mild to moderate pain in musculoskeletal disease. Comparatively, all the NSAIDs are equally effective, and there isn't one NSAID which is superior to the other. However, certain studies have found that ketorolac is comparatively better compared to other NSAIDs and can be considered for usage in case of severe pain. Next is its antipyretic action. So, as you all know, there's a hypothalamic thermoregulatory center in the anti-hypothalamus. So, PGE2 elevates the set point of anti-hypothalamic thermoregulatory centers, and in case of infections or hypersensitive malignancy, this is the mechanism via which we suffer from fever. And once again, by the inhibition of cyclooxygenase enzyme, there's inhibition of prostaglandin E2, and the elevation of the set point of anti-hypothalamic thermoregulatory center is also inhibited. This in turn benefits the antipyretic action. So, like all of you mentioned in the group in the chat box, multiple NSAIDs were mentioned, like etoracoxib, naproxen, diclofenac, aceclofenac, and all. So, all these NSAIDs are not the same. Typically, when we consider any medication pharmacologically, we can classify it based on its chemical structure. In NSAIDs, we classify it in two ways. One is based on its chemical structure, the other is based on its selectivity. Based on the chemical structure, we can classify NSAIDs into salicylates, phenamides, alcohols, acetic acid derivatives, enolic acid derivatives, and pionic acid derivatives. The classification part isn't, the chemical structure part is not that important for you people. I'm just putting it for as part of a completion sake. So of this, as you can see, ibuprofen is a propionic acid derivative, paroxicam is an enolic acid derivative, etoracoxib is a diarylic heterocyclic, and acetic acid derivatives are diclofenac acid. So remembering this is somewhat cumbersome for us because whenever you prescribe medication, we are not usually remembering them based on its chemical structure. We usually remember them on the basis of its mechanism of action or its any specific features each of this drug. That's where the selectivity of NSAIDs comes. Like I mentioned in the earlier previous slides, there are two types of COX enzyme, COX-1 and COX-2. COX-1 is constituted that is present in all throughout our body, while COX-2 is inducible. So NSAIDs also inhibit this enzyme by two ways. Certain NSAIDs inhibit both the COX enzyme, like COX-1 and COX-2, while certain NSAIDs only inhibit COX-2. So we can classify it into non-selective NSAIDs as well as COX-2 selective NSAIDs. So, like you mentioned, the non-selective NSAIDs are diclofenac, ibuprofen, ketorolac, naproxen, piroxicam, and indomethacin. While the COX-2 selective NSAIDs, which we usually say are celecoxib, rofecoxib, and etoracoxib. Of this, I believe in our Indian sitting or in our market, only celecoxib and etoracoxib is available. Other COX-2 selective NSAIDs are not available. So, yeah, this is again another picture which further shows the classification and helps us in understanding how this works. As you can see, the non-selective NSAIDs, diclofenac, ibuprofen, naproxen, like three examples, inhibit both COX-1 and COX-2. As a result, all the prostaglandins produced are also inhibited. while selective COX inhibitors, like COX-2 inhibitors, like celecoxib and rofecoxib, only inhibits COX-2, and only certain prostaglandins are inhibited. This in turn provides us a different side effect profile or adverse event profiles for the NSAIDs. So regarding the general pharmacokinetics of these, NSAIDs absorption, most of them are administered orally. As you know, there are multiple formulations available. There is a oral formulation, the tablets which we commonly prescribe in our practice. There's a parenteral formulation, IV and IM, and there's also the suppository formulation, also the topical application formulation. So once we administer NSAID, most of the absorption happens in the upper GI tract, and the onset of action is within 30 minutes, with the peak effect happening after within 120 minutes. So, like I said, the other formulations are parenteral, suppositories, and topical formulation. The topical formulation is commonly used in our society, and most of the time we also see multiple ads regarding this. Like there are certain sprays or gels which help for muscle pain and all. Studies have found that topical administration is only effective for focal pain syndrome or for musculoskeletal pain. And since its systemic side effects are limited, we can also consider it for patients who are having certain renal derangements also. Now, when we come to the metabolism, so all the NSAIDs are highly protein bound, which means that it's metabolized in our liver by conjugation to sulfate and gluconate compounds, and the system uses a CYP 450 system. And regarding its elimination, most of the NSAIDs are eliminated in our urine in free or conjugated forms. And some elimination also takes place in the intestine in the form of bile. Now, coming to the side effects, the most common side effects with NSAIDs are the gastrointestinal side effect. These are nausea, pyrosis, dyspepsia, bloating, gastrointestinal ulceration. And this is much more common with non-selective NSAIDs. So, like all of you mentioned multiple NSAIDs in the chat group. So when you prescribe NSAID, do you prescribe any other medication with it, or do you just prescribe NSAIDs? Can you just put it in the chat box? So PPIs and H2 blockers are the most popular answers. So is there any reason why do you prescribe it? So yeah, so both PPIs or H2 blockers, this is the most common, this is the reason why which indication by which we prescribe PPIs and H2 blockers with NSAIDs due to the gastrointestinal adverse effects. And like it's mentioned, it's more common with non-selective NSAIDs. However, that doesn't mean that we need not prescribe PPIs with selective COX inhibitors. Like the reason behind is, like if you can recall the earlier slide, is due to the inhibition of PGI2 or prostacyclin, which is present in our gastric mucosa. It promotes the mucosal secretion and bicarbonate secretion. Once NSAIDs, in non-selective NSAIDs especially, inhibit PGI2, the gastric mucosal protection and the bicarbonate secretion is decreased. As a result, there is much more chances of having gastric side effects. That's the reason why we prescribe proton pump inhibitors like PPS, like pantoprazole, rapiprazole, or omeprazole with NSAIDs, or even H2 blockers like ranitidine. So always remember, try to recall the first slide which I mentioned, like the prostaglandins which are produced in and where it's which site it is present. Based on that, the entire side effect profile and entire action of NSAIDs will be much more easier for all. Now, the gastrointestinal side effect is over. Which are the next most common side effect with NSAID is the nephrotoxicity and hypertension. Now, the difference between the nephrotoxic side effect is that this is mediated through the inhibition of COX-2 enzyme. If you're able to recall, in the first slide, I mentioned that COX-2 is an inducible enzyme, and it is present only in certain parts of our body. So kidney is one place where COX-2 enzyme is present, and the nephrotoxic side effect and hypertension, which is induced due to NSAIDs, is due to the inhibition of COX-2. What happens is that once the COX-2 enzyme is inhibited, it prevents the synthesis of prostaglandin E2 and prostaglandin I2. These are responsible for maintaining the renal blood flow. So what normal happens is that in a normal human being, where there is no derangement of renal blood flow, there is not much action of prostaglandin E2 or I2. However, whenever there is a renal vasoconstriction, that is a decreased blood flow to the renal system, the COX-2 enzymes are stimulated and they in turn produce prostaglandin E2 and prostaglandin I2. What it does is that it causes vasodilation of the renal blood flow in order to maintain the GFR, the glomerular filtration rate. So this is the mechanism by which the GFR is maintained in persons who are having renal derangement. However, in such situations, once we introduce NSAIDs to them, the protective effect of these prostaglandins are inhibited. As a result, there's reversal of the renal blood flow. That is, from vasodilation, it goes back to vasoconstriction, and there's fall in GFR, which in turn causes nephrotoxicity and hypertension. So this is the thing which I mentioned. In normal situation, there isn't that much of action of COX-2. However, then there are diseases leading to increased vasoconstriction. Like this can be a renal disease or cardiovascular disease, which in turn can cause increased renal blood flow, or in case of nephrosis, heart failure, use of diuretics or cirrhosis with a decreased blood flow. There is increased vasoconstriction due to the action of angiotensin II, catecholamines, and vasopressin. So what it does is that normally prostaglandins are synthesis which antagonizes the intrarenal effect of vasoconstrictors. That is, it causes vasodilation, which in turn maintains the renal blood. However, once these patients, like I mentioned, those who have renal or cardiovascular disease or cirrhosis or heart failure, then these patients are treated with NSAIDs. There is the protective effect of the prostaglandin is inhibited. And this in turn leaves the action of vasoconstriction unopposed, and which in turn causes renal vasoconstriction, causing further insult to the renal system. Is this part clear to all of you? You can put it in the chat box. So after the renal side effect, the next is the cardiac effects. So again, cardiac effects are much more commonly found with agents associated with higher COX-2 selectivity, and studies have found out that there is not much difference between in a non-selective and selective COX-2. But however, certain studies have found that with selective COX-2 inhibition, the incidence of cardiovascular effects are much more higher. This is one of the reasons why certain COX-2 inhibitors, like say rofecoxib, all were withdrawn from our market. The reason which they pinpoint this is to the decreased prostaglandin I2 production. And other thing which they say is that once there is a decreased prostaglandin I2 production, there is increased action of thromboxane A2, which makes it which is a prothrombotic agent. That is, it increases the risk of thrombosis, which in turn will manifest as a cardiac side effect. This is the reason why there is increased risk of cardiac effects with COX-2 inhibitors or NSAIDs. Next is the hematological adverse effect. This is more common with the non-selective NSAIDs. This is due to its antiplatelet activity. That is, it prevents platelet aggregation. Prostaglandins as such. So once NSAIDs are introduced, there is significant antiplatelet activity. Hence, whenever we are prescribing NSAIDs in patients with hematological disorders or hematological malignancies, especially like leukemias as such, you must always take this into consideration, and the blood routine or the normal platelet levels should be considered. However, we can consider selective COX inhibitors like COX-2 inhibitors in such situations, as the antiplatelet activities of them are much more lower and is considered safer compared to non-selective NSAIDs. And the reason why I said COX-2 inhibitors is that whenever we are treating patients with hematological malignancy, more often than not, they have multiple bleedings in the joints or intra-articular bleedings, which is severe in nature, that won't be usually responsive to opioids. It's an opioid non-responsive pains. And such situations, when we introduce NSAIDs to them, the pain is well controlled. So in such scenarios, we can consider giving them a short course of selective COX inhibitors like etoricoxib. So now regarding the NSAIDs, I'll briefly talk about aspirin. paracetamol, and celecoxib. So aspirin, as such, it hasn't got that much significant role in our practice. It's a traditional NSAID, and the reason why it doesn't have that much significant role in a palliative care perspective is that, or a pain relief perspective, is that the anti-inflammatory activity is only possible at a relatively high dose. That means we need to give them, like, the dosage which they say is 325 milligram tablets if you're considering of aspirin. We have to give 1 to 2 tablets every 4th hour, or 3 tablets every 6th hour, which is very difficult. And the mechanism of action of aspirin is, like all NSAIDs, it's an inhibition of COX enzyme. However, difference is that aspirin causes irreversible inhibition of COX activity in the platelets. This is the reason why which whenever we introduce aspirin, there is an antiplatelet effect throughout the life cycle of the platelets. Next medication which we'll be discussing about is paracetamol. So paracetamol is a drug which is very commonly prescribed. Can any of you put in the chat box your usual prescription of paracetamol? Like, I would like to know the dosage which you prescribe and the frequency, whether it's a BD dosing or a TID dosing or a 6th hour dosing as such. Can you just put it in the chat box? 500 milligram TID, 650 TID, 650, 1 gram QID. Is the dosage common for all the reasons, or do you play with the dosage? Like, you sometimes you feel like in this person only need 500 milligram BD dosing, or 500 milligram 4th hour, 6th hourly, or some persons need 650. Is it just for all the indications of paracetamol? Is it just the same dosing, or do you change the dosage? Change. Okay. What's the most common indication for which all you people are prescribing paracetamol? Other than fever, do you prescribe paracetamol for pain, or do you prescribe it for only for fever? Pain. So I think majority of you are saying that it is you people prescribe paracetamol for pain, which is a good thing, because most of us usually don't prescribe paracetamol for pain. It's usually just limited to fever. And for whenever there's a complaint of pain, we usually shift to NSAIDs. And I won't blame on any of you for that, because if you prescribe paracetamol for pain, the usual reaction of the patient itself is like they will be most of the time disappointed, like you're prescribing paracetamol for pain. They expect some other medication. More often than not, whenever we prescribe paracetamol for pain, the response which I have most commonly encountered in my practice is that they say that we have no fever. Why are you prescribing me fever medication? So paracetamol has got an analgesic action. Even though its mechanism of action is not clearly understood, the popular theory is that it interferes with the peroxidase activity of COX isoenzyme. And paracetamol specifically acts with COX-2. The reason why I said COX-2 is that the peroxidase activity of COX-2 is much more limited in the central nervous system. As a result, paracetamol has got much more helps much very well in centrally acting phase. And other thing is that in case of inflammation, paracetamol doesn't work that well. The reason being is that there's increased activity of peroxides there, and as a result, it interferes with the action of paracetamol. So in case of inflammation or inflammatory pain, paracetamol won't be a good choice of medication. And regarding the formulation of paracetamol, as all of you may be aware, we have got an oral formulation, like tablet formulation is there, both 500 milligram and 650 milligram. There is also availability of syrup formulation, which is more commonly used in our pediatric practice. In pediatric practice, whenever a child complains of pain, the first medication of choice is paracetamol. After paracetamol only, we consider other agents. And paracetamol strength in pediatric, I believe, is 125 milligram for every 5 ml, as well as 250 milligram for every 5 ml. There is also the infusion formulation in certain parts of our country. And paracetamol as such is completely absorbed out from our GI tract, and its peak plasma concentration happens within 30 to 60 minutes. And it is metabolized in our liver with glutathione conjugation, and the metabolite being NAPQIO, which is a hepatotoxic metabolite, which in turn depletes the glutathione levels in our body, causing hepatotoxicity. So in case of paracetamol poisoning, the antidote of choice is N-acetyl cysteine. So, like I mentioned earlier, compared to the other NSAIDs, like you can see, all the NSAIDs got a strong anti-inflammatory action, strong analgesic effect, and strong antipyretic effect. But acetaminophen or paracetamol has got a weak anti-inflammatory effect, weak analgesic effect, and strong analgesic effect, and a strong antipyretic effect. So, in case of for its anti-inflammatory action, we won't consider paracetamol per se. Next is celecoxib. So the only reason why selling celecoxib is it's usually considered as a standard selective COX-2 inhibitor. So it causes reversible inhibition of COX-2 enzyme, and it is also administered orally, and its metabolism in our liver similar to all the other NSAIDs. And similar to other NSAIDs, it's also excreted through our urine, also in our feces. The advantage of celecoxib is that it has got a half-life of 11 hours, and as a result, we can consider OD or BD toxin. Similarly, etorocoxib, which is another COX-2 selective COX-2 inhibitor, which is used worldwide, it has also got a longer half-life, like from 24 to 26 hours. For that also, we can consider OD dosing. And typically, all the guidelines say that we have to avoid all the NSAIDs in severe hepatic as well as renal disease. However, some of the newer guidelines have mentioned that you can consider NSAID in advanced renal diseases, but there are two caveats to it. One is that it should be only used for a shorter course, like only for 3 days to 4 days. And after introducing NSAIDs, we must keep in mind that there will be irreversible damage to the GFR. So whenever the patient is, if any patient is on dialysis or any chronic renal disease, you must always keep in mind. It's not that we should never prescribe NSAIDs in such cases. Based on the patient's prognosis and quality of life, we can make a decision of prescribing NSAIDs in such situation. Like it's a trade-in based on the benefits as well as the side effects of NSAIDs. So that was regarding the first part of the session, like it was about NSAIDs and paracetamol. Is that much aspect clear? Or are there any doubts? You can put it in the chat box. I'll try to clear it right now itself. Someone has raised his hand.
Dr. Arjun, so Dr. H.K. Das has raised the hand. Dr. H.K.
Yes,
Das,
Doctor.
are you there?
Hello. Hello, Dr. Arjun.
Hello, Doctor. Yes, sir.
Hello. Yes. As you have said regarding the maximum of the, I mean to say, NSIs have that side effect of hepatic and renal problem itself. So before prescribing this hepatic and can we go for a liver function test or kidney function test before we prescribe NSIs, especially
So,
for let's say
hello. I think
Dr. H.K. Das, do you mean to ask, like, do we have to do some renal function test or liver function
okay.
test before prescribing NSAIDs? Was that your question?
So I think Dr. Chikedos got disconnected. So I think that might have been question. I'll just answer it based on that. So usually, though there are no specific guidelines regarding doing a routine LFT or RFT, what we usually do is most of the time we just give a short course of NSAIDs. We don't go for a routine LFT or RFT until and unless we know that the person is suffering from a chronic kidney disease or a chronic liver disease. It's not in our routine practice to start do an LFT or RFT. The reason is due to the resource limited setting in which we work in our country. So prescribe because NSAIDs is one of the most routinely used medication in our practice, be it in a palliative care setting or in any other practice. So asking all the persons who come to us with pain and who we are prescribing NSAIDs, it's not a practical solution. However, we can consider a routine LFT or RFT in those patients who we have a suspicion of who are known to have a elevate, like altered renal function prior to, like there are other risk factors also. In those patients, we can consider doing a renal function test. So other thing is, you able 2 or 3 questions are there in the chat box. So no, paracetamol doesn't not fall under NSAIDs. It's considered as another separate entity as such. We don't consider paracetamol as an NSAID. And other was use of ranitide has been smart would be the concern. So what we say is that whenever we are prescribing any NSAID, we can prescribe ranitidine. There isn't any description or more than H2 blockers or PPI blockers, PPI inhibitors can also be considered. There isn't anything which says that ranitidine can't be used. That is based on the guideline, which is based on the Oxford textbook of palliative medicine. I'm mentioning this. Paracetamol dose for analysis. So usually based on the weight is what we usually go for paracetamol. So ideally we have to go for 650 to 1 gram, and we usually go for 6,000 dose with the maximum dosage being of 4 gram. In patients with renal failure or hepatic failure, we usually relax the dosage. That is, we go for a much more lower dose and increase frequency. 3 gram is the dosage which we say for liver failure is what I know. And NSAIDs based on potency, we can't grade them based on potency. All the NSAIDs are considered to be equally effective and equally potent. Only one of the research articles was saying that ketorolac is slightly more potent compared to the other NSAIDs and can be used for mild to moderate musculoskeletal pain. So it is ideal to select a COX-2 inhibitor when you are considering NSAIDs. But again, the added caveat is that the cost and whether these medications are easily available in our setting. COX-2 inhibitors are always considered slightly more expensive compared to the non-selective inhibitors. So based on that, we'll have to make a decision. It's not like it's not one size fits all. It's based on the patient-to-patient scenario. So I think all the questions were addressed is what I feel. Shall I continue to adjoint analysis?
Yeah, sure.
So adjoint analytics. So these are one of the, if you are able to recall the WHO pain ladder, just like NSAIDs, adjoint analytics are also present in all the steps of WHO pain ladder. I'll just take one more question. Yeah, it is recommended to prescribe PPIs and H2 blockers when you are prescribing NSAIDs. It's not, earlier there was a discussion like we need not prescribe NSA like PPI blockers when you are prescribing COX-2 inhibitors, but current concurrence is that you need to prescribe a PPI whenever we are prescribing NSAIDs. Okay. So by definition, adjoint analgesics are medications whose primary indication is not for management of pain, but these have got analgesic properties. So like I mentioned earlier, it's an option every step of the WHO pain ladder. The added advantage of adjoint analysis is that it improves the pain control and also potentially decrease the period required. So this is not a steadfast classification of adjoint analysis, but based on its need, we can classify adjoint analysis into multi-purpose analgesics, analgesic agents used for neuropathic pain, adjoint analgesics used for bone pain, and adjoint analysis which can be used for bowel obstructions. For multipurpose analgesics, the medications are glucocorticoids, antidepressants, alpha-adrenergic agonists. For neuropathic pain, gabapentinoids and anticonvulsants come. For bone pain, glucocorticoids, osteoclast inhibitors. And for bowel obstruction, glucocorticoids, PPI, H2 blockers, and somatostatin analog like Tutrin. So if we go through all these medication, one thing is clear that none of these medications are purely analgesics. These are medications which are used for other purposes, but like the definition says, they also got an added benefit for pain management. So I'll be going through a couple of these medications in the coming slides. So first is corticosteroids. So corticosteroids is a wonder drug which we commonly use in our practice for palliative medicine and is used for wide indications like for management of pain, sometimes even for management of nausea or vomiting, fatigue, and also for anorexia. So in the anorexia guidelines, corticosteroids are also mentioned. So it is one of the most widely used medication in the palliative care practice. And like I mentioned, it's primarily corticosteroids are not analgesic agents. The way it helps us in pain management is it's by its anti-inflammatory effect, and it also impacts transduction in the pain pathway. So, like multiple corticosteroids are there. In our practice, the most common, like I'll come to that. So it's usually used in bone pain, inflammatory pain, neuropathic pain, organ capsule stretch, lymphedema pain, and headache caused due to raised ICP. So when in our practice, whenever we have a patient who is having bone pain as such, NSAIDs are one of the go-to drugs. Other medications which we use is steroids, corticosteroid, and also in malignant spinal cord compression or in the case of malignant bowel obstruction. Pain due to these two scenarios, steroids are our go-to drug or the first drugs which we prefer in these patients. In organ capsule stretch, one example is in hepatocellular carcinoma, HCC. Due to the stretch of liver capsule, the patient will be having severe pain where it won't be normally responsive to our usual analgesics like opioids. And in such scenario, we use steroids. And even lymphedema pain also, sometimes we give a short dose of steroids. And headache due to raised ICP, steroids are again the go-to drug. So as I mentioned, there are multiple steroids which are corticosteroids which are available in the market. However, in our practice, we commonly use one steroid, that is dexamethasone. And there is two reasons for it. One is it's due to its long half-life, and second, it's due to its low mineralocorticoid effect. These two are the major reasons why which we use dexamethasone in our practice. Other medications which we can consider are prednisolone and methylprednisolone. So the advantage with its long half-life is that we can give dexamethasone as an OD dosing. Like only single dosing in the day is enough for its effect. And usually the starting dose, again, it's based on indication. Common consensus is that we can start at a low dose of 4 milligram, or we can hike it to 8 milligram or 16 milligram or even to 32 milligram based on the indication which we. And sometimes if we want to give it as a BD dosing, we don't give it at the night time. Always in our practice, we prefer to give dexamethasone in the morning and in the afternoon dose. That is prior to 3 or 4 o'clock is what we usually do in our practice. The reason behind is that dexamethasone itself, the most common side effect with dexamethasone is sleep disturbance. So this we commonly encounter in our hospital, multiple hospitals when we see, because most of the time the oncology team, be it the medical oncology or the surgical oncology or the radiation oncology, they put the patient steroid and there might be a round the clock dosage, like TID dosage or BD dosage. And the BD dosage will be in the morning at night. And most of the time we get the referral that patient is restless or patient is showing altered behavior as such. This is due to the sleep disturbance caused by the steroid, which in turn initially manifests sleep disturbance, which will further progress into delirium. So whenever we are prescribing steroid or whenever you're seeing a patient who is on steroid, always make it a point to see what is the frequency or what are the timings in which they're getting steroids. Even if it's written as a BD dosing, always ensure, discuss with the primary team that it would be better to give it prior to the evening, like morning and afternoon. Because since it has got a long half-life, there won't be much more difference in the effectiveness. Now, coming to the side effects profile of steroids, the most common side effect, like I mentioned earlier, is sleep disturbances. There is also risk of hyperglycemia. Then delirium, like I mentioned, is one of the most common side effects which we encounter in our practice and is unfortunately missed. And there is myopathy, osteoporosis, and if we are using steroids for longer term, pushing out symptoms can also happen. However, once we discussed with the endocrinology team regarding hyperglycemic side effects, the consensus from the endocrinology department is that you can prescribe steroids based on the benefit ratio. Even though there's a risk of hyperglycemia, most of the time what they see is that for the shorter term, the benefit of steroids outweigh its adverse effect. So it is always beneficial to put them on a steroids for a short course. And the other adverse, what they say is that only after 6 weeks is one which they are much more concerned is what the endocrinology team is usually saying. So you need not be worried when you are putting steroids a patient who is a non-diabetic. We can always prescribe steroids in diabetic patient also, with the caveat being the short-term benefit outweighs the long-term side effects. The next class of adjuvant analgesics are antidepressants. Of this, two antidepressant categories are most commonly used in our practice. One is TCAs or tricyclic antidepressants. Other is serotonin norepinephrine reuptake inhibitors. So TCAs, the mechanism of action is that it acts on a disciplinary pathway via the inhibition of norepinephrine and serotonin reuptake. It also interacts with the sodium channels. And the most common TCAs used in our practice are amitriptyline, and nortriptyline. You can most of the time you see a combination of pregabalin or gabapentin. I believe it's gabapentin N10 or pregabalin N10, where there's a combination of pregabalin and gabapentin and nortriptyline. The dosage of nortriptyline is 10 milligram HS, and the dosage of amitriptyline is 25 milligram HS. Now, the most common side effects with TCAs is its sedation, anticholinergic effect, postural hypotension, and sometimes it can also cause arrhythmia. Of this, the anticholinergic effect and sedation are the two things which we need to keep in our mind. The reason being, most of the time our patients are frail or belong to a much more elderly age group. So whenever we are starting all these medications, like especially TCAs, there's an increased risk of sedation. There's also increased risk of fall in these patients. So that is one thing which we need to keep in our mind. Other is the anticholinergic effect. This is like dryness of mouth, constipation, and urinary retention. So whenever you're seeing an elderly male, there is an increased risk of pH for these patients. So always keep that in your mind when you're prescribing and TCAs for them. And even though the starting dose is, like I mentioned, 25 milligrams for amitriptyline, the common dictum is that we have to start low and escalate the dose every 3 to 4 days or every 1 week, once in every week. And the hiking is by 12.5 milligram for amitriptyline. Like if we start with 25 milligram, we hike it to 37.5, then to 50 milligram, then to 62.5, and then finally to 75 milligram. The normal dosage which we use TCAs doesn't have an antidepressant effect in common practice. So that you need not worry about this antidepressant effect. Next antidepressant which we use in our practice is SNRIs. The most commonly used are duloxetine and venlafaxine. So these are considered first-line agents for neuropathic pain, and compared to TCAs, the side effect profile of SNRIs are much more better. Much more better. So there's lesser incident of side effect profile. And the usual common side effects which we see with them are nausea, somnolence, and sexual dysfunction. And the dosage of duloxetine is 60 milligram daily, while for venlafaxine it is 35 milligram. Sorry. And both these TCAs and SNRIs are considered to be the first-line agents for neuropathic pain. Whenever we have a patient with neuropathic pain, I believe neuropathic pain was covered earlier or it will be covered in the coming session. So the first drugs which we use are TCAs and SNRIs. Now, the next group of agents which we consider as adjuvant analgesics are gabapentinoids. So gabapentinoids are a combination of, like, in gabapentinoids category, there are two medications. One is gabapentin, other is pregabalin. So I believe these two might be much more popular in our practice, and I believe most of us will be prescribing this for diabetic neuropathy. So the way gabapentinoids work is that it decreases calcium influx, which in turn affects depolarization, which in turn affects the signaling. And like I mentioned, it's commonly indicated for usage in diabetic neuropathy, chemotherapy-induced neuropathy, and for neuropathic pain. The starting dosage for gabapentinoids, like for gabapentin is 100 to 300 milligram HS, and for pregabalin is 25 to 75 milligram HS. And like I mentioned earlier, all these agents, even when we are escalating dose, we have to escalate it gradually. Like after 75 milligram, we go to 150 milligram, like that, instead of going from 75 to 300 as such. And the side effect profile of gabapentinoids are somnolence, dizziness, confusion, and peripheral edema. Of this, dizziness and somnolence is of profound importance because most of the time, whenever we start gabapentinoids, within 1 or 2 days, the patient or the caregivers will report back to us with a complaint that the patient, he or she is sleeping the entire time, they're not even waking up. So this is one of the most common side effects which we see with gabapentinoids, and we have to keep in mind when you are prescribed this for an elderly age group. Other thing we have to keep in mind is that sometimes gabapentinoids itself can cause delirium in such an age, even though there aren't much documented proof of it. We find it in our practice routinely. Like once we start gabapentin, so that within 2 or 3 days they develop delirium, and once we stop this medication, the delirium is subsided. And once we consider other anticonvulsants, there aren't much high quality evidence regarding their practice use of these medications in our management of pain. However, a trial of them, like phenytoin or valproate, can be considered if the pain is refractory to opioids, and there isn't much response to trial of other neuropathic pain agents like TCAs or gabapentinoids or SNRIs. Carbamazepine has got slightly beneficial effects in trigeminal neuralgia, and certain documents are there, studies are there which also state the same. However, other anticonvulsants, that much beneficial effect, nothing has been documented or nothing has been found out in multiple studies. The next group of adjunct analgesics are alpha-2 adrenergic agonists. And again, the mechanism of action is by preventing signal transmission to the brain. This is by the inhibition of norepinephrine release. And the most commonly used in our practice are clonidine, quizanidine, and dexmedetomidine. So the clonidine is commonly used as an antihypertensive, but it also works very well for management of pain, especially neuroirritability in pediatric age group. Quizanidine has got an antispasmodic effect, and the dosage with which I start is at 4 milligram. And based on the effect, we can hike it to 4 milligram BD or TID. Dexmedetomidine is usually used as found in a parental formulation, like an injectable formulation, and usually we use it as in a sedation form. And it has multiple studies have found that it also decreases the need of opioids whenever we start them on dexmedetomidine. Again, the side effect profile is somnolence and hypotension. The next group of drug is sodium channel blocker. So lidocaine is one agent which helps in managing pain, especially neuropathic pain. The way it works is that it modulates the neuropathic pain by inhibition of blocking sodium channels and also via its NMDA receptor antagonist action. The side effect is common side effects which you see it is perioral numbness, sedation, lightheadedness, tinnitus, and headache. So lidocaine or lignocaine infusions can be considered whenever patient is having severe pain crisis or neuropathic pain crisis, which is not responsive to opioids or any other NSAIDs or steroids. In such situations, we can consider giving them a lidocaine trial or lidocaine infusion as. I've just kept it as for a completion sake for this. I don't think that you won't be needing that much in your practice. And other agents which are present which can also considered to adjuvants are cannabinoids, topical agents, bisphosphonates, and RANKL inhibitors. So cannabinoids, even though in our practice we usually encounter people and even health workers asking why can't we use cannabis, till now no data has been proven which says that cannabinoids helps in pain management, and the only indication for cannabinoids has been till now by FDA is for practice of for management of anorexia and nausea. And topical agents, like I mentioned earlier, NSAID ointments or lidocaine ointments or capsaicin ointments can be considered. The disadvantage, again, that much beneficial effects are not been found from multiple research which has been out. Capsaicin has been ointments can be used like very low concentration ointments are there from 0.075% to very high concentration, like 0.8%, has been approved for use for hepatic neuralgia pain. However, its adverse effect, like it causes burning sensation, is one thing which you have to keep in mind. And bisphosphonates are RANKL inhibitors. These are considered in case of pain due to bony lesions or bony meds. And the way they work is that they don't inhibit pain per se, but they prevent the bone resorption and prevent molecular damage to the bone by inhibition of osteoclastic activity. So these are also other agents which we can consider whenever patients having pain. Bisphosphonate RANKL inhibitors, especially for bony meds as such. So these are the references which I used. So I think that ends my presentation. If there are any doubts, you can just put it in the chat box. I'll try to answer.
Thank you, Dr. Arjun, for such an elaborate session. There are a few questions in the chat box.
So yeah, one by Sheila, rule of setting can be used in chronic OA. Ma'am, OA as such, are you considering osteoarthritis or is it anything else?
The osteoarthritis.
Yeah. So, ma'am, duloxetine or all the antidepressant agents can be used for osteoarthritis or chronic pain. However, the way it works is slightly different when we consider. So, if you are aware of the total pain picture, the way we consider, so we should also consider the psychological aspect. So all the antidepressants has got that added benefit also. Once the psychological aspect is also taken care of, the depression will be there for most of the time in patients who are having chronic osteoarthritis. So once that component is taken care of, pain also subsides a bit is what they say. Otherwise, for bony pain, duloxetine, it doesn't work that much. Only the psychological aspect is what multiple studies have found. So we can consider in such situations. Uh, yeah, Dr. Naveen Kumar has raised his hand. So can you unmute yourself? So you can put it also in the chat box if it's unmuting is difficult.
Hello, good evening, sir.
Good evening, sir.
Sir, one of my patient had a total knee replacement, and during the procedure, unfortunately, she got foot drop, sir. And in this procedure, she got neuropathic pain in her foot, right foot, sir. And the consultant prescribed her gabapentin and duloxetine, but these drugs is not helping her. So what can else we do, sir?
So like one thing which we need to know is the dosage at which gabapentin and duloxetine has started,
Yes, sir.
Dr. Naveen. Yeah.
Yes, sir.
Other is
During
yeah.
yes, sir. During firstly,
No, you can
she is having like 300 mg of the gabapentin and 20 mg of the duloxetine on the night, and gabapentin BD 300 mg, and not having like much benefit.
okay. So Dr. Naveen, in such situation, one thing we need to consider is once we can consider rotation to other neuropathic agents. Like if gabapentin doesn't work, you can also give a try of like amitriptyline as well, or you can go for a combination of both these things. Like you can also consider
Sir,
weaker opioids. Hello?
sir, already combination was tried, like GABA 80 was
Yeah.
tried, but
So yeah,
there is
we
no
can
use, sir.
if there isn't any adverse effect per se, we can again escalate the dose, Dr. Naveen. Like there's what we usually say with Arjun analysis is there isn't an upper limit. What we usually say is until there isn't if there is no side effect profile or there is no toxic effect, we can hike the dosage again. Other option is you can consider combining it with another analgesic agent, like weaker opiates like tramadol can be considered, or even NMDA agents can also be considered in such patients. The
You,
next aspect would be like to reevaluate what is the cause of pain. There will be pain due to the foot drop itself, but is there any other also like any psychosocial issues or psychological aspect due to this? Whether she's unable to go to work or a day activities or daily livings are affected due to this foot drop. That also can
yes, sir.
cause significant. Hello?
Pain is purely of the foot drop, sir, because the pain is radiating from her ankle to the
Yeah.
fingers. And now her finger is moving. It's already 3 months when she had like TKR, but thumb is not responding to the treatment. Only thumb is
So
left.
yeah,
Yes, sir.
like I mentioned, you can give a short course of steroids. Also reevaluating whether it's just a physical pain that is affecting her. Because even after high
Okay,
agents
sir.
of neuropathic pain, if it's not responding, there will be also other components that might be causing the pain for such situations. So again, doing a reevaluation will be a better thing, Dr. Navi. So just blindly
Okay.
hiking dosage is what I would suggest.
Okay, sir. Okay, sir. Thank you, sir.
I hope that was helpful, Dr. Navi.
Yeah, thank you, sir.
Thank you, Dr. Arjun. So there's another question. What about dosulipin?
Unfortunately, I'm unaware of this medication as such. If possible, I'll just look about it and then get back to you, ma'am. I don't know what dosilipin is. Is it a trade name or is it the generic name as such?
I think it is a tricyclic antidepressant, as far as I know, which is usually given for depression and an associated anxiety. As far as I know, we have not prescribed dosulipin for neuropathic pain as such or any kind of pain as such till now. So that's what I know about dosulipin.
Regarding the tricyclic antidepressants, the current data is just limited to amitriptyline and nortriptyline. Other antidepressants, they have found out that are not that much effective. And all the data which we have is limited to just amitriptyline and nortriptyline. And I'll just look about it, ma'am. Like if we get anything, I'll just update you people. Like I will get through it somehow. Okay. So next question is,
And
can
there's
two
another question.
anticonvulsants be
Yeah,
prescribed? No, Ashwin, you can just do it.
no, I just thought I can read it out for you.
Yeah, that would be fine because the chat box isn't working. It seems to be.
Yeah. Can 2 or 3 anticonvulsant or gabapentin, pregabalin, or amitriptyline be prescribed together at the same time if one drug isn't controlling the neuropathic pain effectively?
So the way we go about this is that you start with all these three at a time. We start with one neuropathic pain agent, and after escalating the dose somewhat, then only we consider adding another agent. The reason behind this is that most of the time it prevents polypharmacy. Our patients, most if you prescribe 4 or 5 medications, they won't be taking all of these medications together. As a result, usually it's better to start with one medication at a time, and based on the response, we will escalate it. The way the WHO ladder goes for neuropathic pain is that starting with one anti-neuropathic pain, like you can start with an TCA or an SNRA or a gabapentin. After that, if the pain is still persisting, then we combine to the second step, like one of the TCAs along with the gabapentin. Even after that, if the pain is still persisting, we hike it to a opioid comes into picture, and NMD agent comes in. So it's always better to start with one agent, and if the response is insufficient, then only we consider adding the second agent. Other issue with is that we be able to understand what is the side effect or which of the medication is causing the side effect. Because most of the neuropathic agent cause sedation as its side effect. So if you prescribe all 3 or 4 of them together, the patient will be sedated most of the time. We won't be able to get a clear idea which of the medication is causing the side effect. Is that clear?
Yeah, that's fine, Dr. Arjun. So there's one more question. Is there any guideline on how you use a combination of these medications?
So guideline as such, the one which we follow worldwide is the WHO plain ladder for neuropathic pain, ma'am. There isn't any fixed guideline as such. So pain ladder, what it says is that first we have to use a single agent like TCA or SNRI or a gabapentinoid. After pain is persisting, we hike it to combination of both these two medications. And always once we escalate, the way we escalate a dose is based on the response and the side effect profile. If none of them is happening, we can keep on escalating the dose. However, always check into drug compliance. So there isn't any guideline per se for this. So next is carbamazepine in trigeminal. Sorry, doctor, but I haven't used carbamazepine in trigeminal neuralgia. I've used amitriptyline and nortriptyline for it, so I won't be able to help you in that. Dr. Hashman, would you be able to answer this?
Yeah, in case of trigeminal neuralgia, I think we can start with 50 to 100 milligram thrice daily and then increase it by every 2 weeks. Mostly we can go up to 200 milligrams, and the maximum dose is 1 gram in a day. So that's what I have, like, we have used in patients with trigeminal neuralgia.
Next question is, do you consider fixed dose combination? Should we ideally we go for individual drugs, Dr. Nishan. We don't prefer a fixed drug combination. Like I mentioned, it's always easier for us because even though giving a fixed drug combination is easier from the patient side, it's the disadvantage is that we won't be able to have a control over the dosage of each medication. So we don't prefer a fixed drug combination. We usually prefer an individual drug combination in our practice. Next question, how do we combine medications in oncology when pain is multifactorial? I didn't understand the question. Can you just reframe it, or can you just ask me once again? Like, what are you? Dr. Azmi Kumar Velu.
Dr. Arjun, so for 2 more minutes, I think we can take questions, and then by
Okay.
6:05 we can move to the case presentation.
Okay, fine, yeah.
Yeah.
So yeah, so multifactorial pain, what I understand is like suppose the causative pain is again we have to reassess what's the cause of pain here. Usually, if it's an is due to disease itself, like in case of bone mets as such, there's a rule for palliative RTO for such pain. And if it's due to any abdominal malignancy, for example, ovarian malignancy as such, chemotherapy also has got a role to play in this. It's not that only pain medications can play. Always we work in tandem with the primary treatment team. Based on their help also, we manage pain. And combination of medication, usually in oncology setting, we start with opioids and we escalate it, and based on the cause of pain, suppose like I mentioned earlier, if in the HCC, if we feel like the capsule stretches the cause of pain, we give them a short course of steroids and see how the response is. Always, it's not like we work in tandem with the primary team.
If you give paracetamol on empty stomach, how is it is effective?
I haven't faced any problem with that. We can give it in empty stomach also is what I say. Usually paracetamol comparatively gastric safe is what we see.
Yeah, paracetamol does not have any gastric side effects, so you can give it at any time.
One question is,
And
skeletal muscle
and
relaxation has any role? Yeah, sorry, Ashwin.
Yeah, that's what I was about to read.
Yeah, skeletal muscle relaxation has got a huge role in pain management. So quizanidine, like I mentioned earlier, is one of the agents which we prescribe. So we started 4 milligram as such per day, and we hike it based on response. That's a preferred. Baclofen is another agent which we can try. However, the drowsiness due to baclofen is a problem due to which we do not prescribe it. Patients suffering from cirrhosis. So yeah, ma'am, for cirrhosis, again, what we usually do is we relax the dosage frequency. Like instead of going for 6th hourly, can go for TID or BD dosing. And the dosage also, like for paracetamol itself, maximum which they say is 3 gram. We can go up to 3 gram for cirrhosis. Opioids also, even though there's a steadfast rule, we can go for 6th hourly dosage or 8th hourly dosage in such patients. It's again based on patient to patient how their response is. Next is maximum dose of gabapentin. Yeah, so maximum dose which we can go is 2,700 to 3,600 milligram for gabapentin.
Okay, thank you, Dr. Arjun. I think there are many questions, but as it's 6:05, I think we can move to the case presentation, and after the case presentation, we can take up more questions.
Okay. Thank you, Dr. Arjun, for a wonderful session. And we are now moving on to the case presentation by Dr. Ashra Madam. So I'm presenting the slide now. Is it visible now? Hello.
Ambadi, she says she's not able to.
Pardon? Okay.
Dr. Astra?
Yeah, good evening.
Yeah, you can start with the case presentation for today.
Okay, thank you so much. Good evening, everyone. I am Dr. Asra Kishlu. I am currently a palliative care physician in the Government Medical College, Jammu. So today, my case presentation is regarding the step 1 of the pain management, or regarding the non-opioids and the adjuvant. So my patient is a 28-year-old female who was diagnosed with a low-grade glioma tumor. When she presented to the hospital on the first setting, she presented with complaints of headache, which she described as very dull aching pain. And she had a history of seizure 2 episode, which were tonic-clonic seizures with loss of the consciousness just 1 times. She also complained of dizziness and weakness as a whole. And along with that, she complained of lack of appetite along with nausea. So regarding the history of the illness, 28-year-old female patient, she belonged to the middle class family, and she is newly married. And just 8 months ago, she got married. She just 2 months ago, she was in good health. Then she had suddenly developed headache mainly and dizziness, for which later she presented in the neurosurgery OPD with complaints of headache, dizziness, and 2 episodes of seizure. When we come to the pain part, the physical domain of the pain, The precipitating factor which she described were a loud noise and when she wakes up in the morning generally. And for the quality of the pain, it was dull aching pain, which was generally localized to only head till now. And it was mild to moderate in the severity. According to her, the timing was generally when she woke up in the morning hours, and sometimes it was also in the evening. She suffered from this pain. It was generally relieved by taking medications, NSAID medication like paracetamol and naproxen. Few of the prescriptions on the naproxen was seen. Then after that, the few baseline investigations were done along with MRI, and later on she was sent for the NCCT scan of the brain. And after that, after the report, she was sent to the medical oncologist. And 1.5 months ago, she was diagnosed with a low-grade glioma tumor, for which she then underwent surgery and radiotherapy. She is currently having radiotherapy also, but still patient complained of symptoms like pain, lack of appetite, which was progressive lack of appetite. Then one episode of seizure was seen. After that also, then nausea and few other symptoms were seen. So the palliative care unit was involved. And after that, she's on treatment with the radiotherapy department in the palliative care. Next slide, please. Okay, on examination, it was seen that the patient was conscious and oriented. Her peripheries were slightly cold. Temperatures were almost normal. Pulse was recorded at 68 beats per minute. BP was 100/70. Our CVS chest examinations were almost normal in findings. When the pain assessment score was done using a numeric pain rating scale, it was found to be 3/10. Next slide, please. Okay. This is first the history of the treatment which she received before she came to the palliative care unit. The injection Pentoff was given, 40 milligram. Injection Odensetron 4 ml OD was given. Tablet paracetamol 650 TDS was given, and tablet phenytoin 300 was given. The routine examination I told you all were done, like CBC. Hemoglobin was found to be 11 grams. Then serum and keratin, serum urea and creatinine were within the normal ranges. Serum electrolytes were within the normal ranges. Then findings were seen in the MRI brain and the NCCT brain. So when we come to the psychological aspect, she was highly disturbed. She was newly married and living with her in-laws. While talking to the patient, it was seen that she was too concerned about the future as a whole, because they were trying to conceive and start a new family. Now she was feeling totally hopeless. And she was continuously crying and saying statements like, "Why is this happening to me? I have not lived my life yet. I just started living my life. Will I ever be cured again? Will I ever get pregnant again?" She, before all this, she was a very religious person. So it was found that she was in severe distress, both emotionally and spiritually. Presently, she's taking these medication, injection Pentoff. She's admitted in the hospital still, and she's taking Pentoff 40 milligram IV, injection dexamethasone 8 milligram. Injection Odensetron. She's complaining of the nausea, so these medications are added as well. Tablet paracetamol 650 milligram is kept as SOS. Tablet phenytoin 300 milligram oral. Tablet levetiracetam 500 milligram oral TID is continued till date. Next, please. So her main complaints were headache, which is ongoing still. On and off symptoms are seen, and she's very concerned if the seizures will reoccur if she stopped taking the medications. And one of her most important concern was regarding the pregnancy concerns, if she will ever be able to get pregnant. So to summarize, the 28-year-old female developed headache, dizziness, and 2 episodes of the seizure. Later, she was diagnosed with low-grade glioma, for which she underwent surgery and radiotherapy, and currently she is also taking radiotherapy for the same. Pain relief score with the paracetamol was seen, and in all those other drugs was seen more than 10 hours, and seizures are currently under control with the medications. So these are the discussion points. Thank you so much.
Thank you, Dr. Asra, for the presentation. Participants, if you have any questions, you can post in the chat box. We can discuss regarding that, regarding this case especially. And she also has 3 questions there. Role of paracetamol in mild pain, that is what we were discussing about. Dr. Arjun had been speaking a lot on that. So as in palliative care setting, and as well as in other settings, I would say paracetamol is one of the best drug for mild pain. When the pain score is usually between 1 to 3, paracetamol is a drug that is being preferred, and usually it is calculated in calculated in dosages of 10 to 15 milligrams per kg per dose, and then it is usually given round the clock. So when we say round the clock, every 6th hourly is the usual pattern that we prefer, and it is always best to give paracetamol via oral route to see whether it is really helping, and then you can move to other routes if needed only. And the maximum dose of paracetamol in a day is 4 grams. So that is a main role of paracetamol in mild pain. Any other questions you can post and we'll be able to take it up. So there's a question like, what are the other drugs that can be prescribed in this case? As you can see here, this patient has mild pain, and Dr. Azra has started her on paracetamol already. So she has given 650 milligrams thrice daily. I would actually suggest that she calculates the patient's weight and then calculate it according to her weight, and then give it round the clock every 6th hourly. That would be much more helpful. And also in step 1, as we had discussed previously, it is always we can add NSAIDs also. So that is what WHO analgesic ladder step 1 says. So the other drugs that can be used are like, what Dr. Arjun had been speaking for a long time now, that is ibuprofen. The selective and non-selective inhibitors are all that can be given here. So that depends on the pain assessment. So based on the pain assessment, we can move for other drugs also if needed. Can we give paracetamol as, yeah, please, Dr. Arjun.
We can also consider mannitol in this patient if the raised ICP is the cause of pain in such scenarios. Like sometimes in any cerebral tumors, cerebral metastasis, raised ICP might lead to severe pain, and even if you hike to NSAIDs for paracetamol, it won't work. So in such situation, you can give a short course of mannitol, as well as like one of the shadows, RT will also help in decreasing the pain. However, due to RT, initially itself after 1 or 2 fractions of RT, the pain won't subside. It might increase due to the edema caused due to radiation. In such situation, we have to continue them with steroids as such. These are other things which we can consider in such scenarios.
So that's another question, Dr. Arjun. Can we give paracetamol as 1 gram BD?
Yeah, we can instead of going for BD, we can go for TID of 6 hourly also. Why BD dosing? I didn't understand. Paracetamol, like the dose doesn't determine the duration of action of the medication. So ideally, if we say we have to give it 6th hourly, so we can give it 6th hourly, or we can also go with TID if 6th hourly is not feasible. BD, I won't suggest BD until unless there's an underlying liver or some other problem.
That's another question. Like, can we start with parenteral preparation and then shift to oral medication? Will that be helpful?
The way we go with parenteral medication is that suppose if the patient's general condition is too poor and we feel like the patient won't be able to take orally, then at that point we consider parenteral medication. However, or also sometimes in severe pain also. Once the symptoms are relieved or the patient's general condition improves, it's ideal to shift it back to an oral formulation. Because at the time after the initial pain management, once we discharge the patient, shifting them from a parent to oral form at the time of discharge isn't a feasible thing. Ideally, we have to shift it 2 or 3 days prior to discharge, and then we have to see how the response is with oral medications. That is one thing which I would suggest.
Yeah, so many comments are coming up. Like many of you are posting your views on managing this patient. So that's really nice to see.
Can I add something?
Yeah, sure.
Yeah, actually, I've seen many comments regarding the counseling. Mhm. Okay. So I have seen many comments regarding the counseling part. I want to clear the part is that right now the patient is undergoing counseling, but as I told you, she is a very young patient, and to be diagnosed with this cancer at this stage, and she wanted to get pregnant, so she's undergoing the counseling right now. She's what can I say, very disturbed, but our team is trying to do the counseling as best as we can. And regarding the injectable therapies, first of all, she's hospitalized still. She is still under the radiotherapy department. She's hospitalized and she is very reluctant to take the drugs orally. So we have the same plan when we are planning when we'll be planning to discharge her at that time before 2 or 3 days. The general protocol is before discharge the patient, 1 or 2 days before we try for the oral therapy. If the patient is able to take it, then we shift the patient directly to the oral therapy for observation for 2 3 days, and then we discharge the patient. That's it. Thank you.
Thank you, Dr. Rasra, for that. Yeah, so I think, especially in this case, as a patient is a 20-year-old, 28-year-old, and she has pregnancy concerns very young with a brain tumor. Breaking bad news and the communication plays an important role. As Dr. Azra also mentioned regarding that, it would take a lot of time to deal with it and to address it little by little. So yeah, that is an important factor. As we all know that we should consider pain as total pain. It's not that we should just address the physical pain. We need to address all the components of total pain. So that emotional support also plays an important role for her pain relief. Dr. Arjun, so there's one more question. Which is the best medicine for neuropathic pain out of all?
Yeah, so Dr. Divya, there isn't any specific medicine which we consider superior to all the neuropathic pain as such. It's always, like I mentioned, it is always based on case to case scenario. Like from patient to patient, the medication varies. For some patients, amitriptyline works very well. However, for some of them, duloxetine might be the one that works. So there's not one medication that works very well for neuropathic pain. It's again like based on what is the cause of pain and what is responding to it. In some situations, we also go for what we call as an NMDA burst therapy, like ketamine burst therapy. That is, we give them a short dose of ketamine, and once the pain cycle is broken, we switch them back to other neuropathic pain agents. There isn't one which we say is superior to all the other pain medications, in neuropathic pain especially. I hope that answers that question.
And Dr. Arjun, there's one more question. Like, what is the role of adjuvant drugs in this case? In this case, especially.
So in this case, there are two. One adjuvant drug is steroid itself. As you can see, she's having nausea and vomiting, and there is headache. So steroid is one adjuvant drug in this, which, as a result of decreasing the peritoneal edema, will help us in managing her pain as well as her nausea and vomiting. That is one adjuvant drug which we can consider. Other adjuvant therapy is RT. Radiation itself can be considered as an adjuvant therapy in this for pain management, as its primary function here is to decrease the disease. So once the RT is done, that is also an adjuvant role of adjuvant therapy in this case. That's one thing which I would say.
Yeah, so I think most of the questions are answered. If there is anything else, please post it in the comments. We have 5 to 7 more minutes.
I think Hashim, one was about spiritual pain. So, ma'am, spiritual pain is a slightly trickier topic. I don't think, like, if we discuss about spirituality, the entire discussion, like, it won't be over in one discussion as such, ma'am, because the way we perceive spirituality is different. Each one of us is seeing spirituality in a different way. And ideally, it's not like spiritual pain. How can we address spiritual pain by counseling? Is that most of the time when there's severe distress for a person, it's not about finding a solution for a distress that we need to do in counseling. Once we speak to them, they find we as an outlet where which they can vent out their frustrations or their distress. And once their frustration is vented out, their distress comes down to them. So that's the way in which we can manage the spiritual distress which they're having. Like it's like having providing for a source to which they can express their problems and concerns. That's one way in which counseling helps in such situations.
There's a question about ketamine. So I would say that regarding ketamine, the entire session will be dealt in difficult pain topic, especially. And with respect to ketamine, usually it comes in the step 3 of the neuropathic pain ladder. So ketamine and IV lignocaine are usually preferred for the management of neuropathic pain. And the dose of ketamine that is generally used is zero point 0.2 to 0.5 milligrams per kg body weight, and it is generally given in a kind of a continuous subcutaneous infusion at around 50 to 100 milligrams per day. And it is very very important to keep the patient under complete observation and then watch for side effects like dysphoria, hallucinations, nausea, vomiting, dizziness, and all of it. I just wanted to add a little bit on that, as there was a question regarding ketamine, but it will be dealt in detail in the difficult pain session. Any more questions?
Uh, I think there's one question regarding lidocaine. So what we do is just like ketamine, we also give an infusion of lidocaine to the patient. The dosage which we go is 2 mg per kg, and we give them an infusion over 30 minutes of lidocaine and all. And after that, the major aim here is to break the cycle of pain actually. Because once there's chronic pain, the pain's vicious cycle of pain happens. And once we break the pain, our other analgesic agents works. Like I had two recent situations in which we had to give lidocaine infusion for the patient. Once the infusion was given, the pain cycle was broken. We were able to switch them back to methadone or other like opioids as such. The reason here being the pain cycle is being broken. And once the cycle is broken, the normal analgesics have got much more better effect. This is basically where the action of its NMD action. Like once the NMD receptor is blocked, the normal analgesics also works much better. That's where we use lignocaine infusion. So ideally, what we say is that should also work. So usually, ICU setup is no needed for lignocaine infusion. What we do is we have to monitor the vitals, also for perioral numbness, as what is a vitals in the sense BP, pulse rate, and the sedation of the patient, respiratory rate, and perioral numbness. These are the four things which we always monitor when we give lignocaine infusion. And if whenever the patient says of any perioral numbness, it's ideal to stop that infusion at that time itself. That's what we say. Because before arrhythmia, perioral numbness is the first side effect which we face before going for arrhythmia. So once we find out the patient is having perioral numbness, it's ideal to stop the infusion attack. So we usually don't for subcutaneous dosage of lignocaine. We usually go for an IV infusions, what I've seen in my practice.
Thank you, Dr. Arjun, for adding that. Yeah, thank you everyone for such a wonderful session, because there were many questions. I hope most of the questions were answered. If there are a few more questions, you can always mail that to Ambari and then he'll get back to us.
Okay. Okay. Thank you, Ashmat Madam, for the wonderful facilitation part. And thank you, Ashra Madam, for the case. Thank you, Dr. Arjun, once again for the wonderful session. Thank you all. And for your kind information, participants, I will be sending a feedback form to you after the session. And also, we will be releasing the assignment tomorrow for the first two sessions we had. So, the rest will be conveyed to the group. Thank you.